Good afternoon, everybody. We will start the third session for today, and we will have mostly about feto-maternal obstetric. Today, our guest is Dr. Abdullah Khan. He is a Vice Chair and Division of Director of Maternal Fetal Medicine and Surgery at Helsinki University in USA. He's a well-known figure, really, especially in Bahrain. He gave us a lot of lecture previously, and he will talk today about morbid adherent placenta and the option and management. Actually, this is a hot topic and is a nightmare for obstetrician. Please, Dr. Abdullah.
Thank you. Thank you very much. So I'm going to try to make this as exciting as possible. I would like people to interact with me because this is a very important subject and comes close to my heart. First of all, I'd like to thank all of the organizers of this symposium to welcome me back to my home country. I was born here, I'm a Bahraini, and I have been living in the United States for about 33 years, and that's home for me right now. So just to give you a background about abnormal placentation, I'll give you a story. About 18 years ago, maybe 19 years ago, I was a junior consultant at a major academic center in the New York area. We had a patient with placenta previa, one prior C-section, and back then we never focused a lot in terms of diagnosis and aggressive management of patients with placenta previas and perquita. She had one episode of bleed. We admitted her to the hospital. She went home. At 29 weeks, she had the second episode of bleed. We did the ultrasound. She had placenta previa. So we said we should keep her in the hospital until a definitive plan for delivery. Everything was fine, and finally, at about 33 weeks of gestation, while in the hospital, the patient bled. And the bleed was catastrophic. We rushed her to the operating room. We did a laparotomy, and ultimately we delivered the baby, and of course, the whole pelvis was distorted. She bled. We transfused her 33 units of blood, not to include other blood products. There was injury to the pelvis. She lost half of her bladder. She was in the ICU. We had to leave her belly open. We packed her, and she had to undergo 3 surgeries. And the first surgery took me over 12 hours, and I had more than 7 consultant surgeons helping me out. So it tells you that this is the problem with placenta previa, is when we encounter this condition and we're not prepared, things go wrong. And back then, 18, 19 years ago, I decided to take an interest, and we established the first center for abnormal placentation in the United States. You know, a favorite statement of mine by Ibn Sina in AD 980, and he said one thing: there are no incurable diseases, but only a lack of will. And I think this is very important for everybody in this room. But I'll give you another statement. And the other statement is the following: once you decide on your occupation, you must immerse yourself in your profession. You have to fall in love with your profession. Never complain about your work. You must dedicate your life to mastering your skill. This is the secret of success and is the key to being regarded honorably. This is a person that I absolutely enjoyed listening to, and he is really not a doctor. He's a chef in Tokyo, and he makes sushi. So we're not going to talk about sushi, but I think he inspired me because these are his words of wisdom. So we're going to be talking about a comprehensive update on abnormally invasive placentation this afternoon. I hope everybody will become interactive. I have no financial disclosures, and I'm not going to be discussing any off-label medications during my talk, so I have nothing to disclose. The objectives is to go over the basic pathophysiology of abnormally invasive placentation, what it is, how it occurs, talk about the epidemiology. I am sure this is not only a problem in Western civilization, but this is a growing problem all across the globe, all right? We'll focus on diagnosis, we'll talk about surgical intervention, what is the best way to surgically handle patients with abnormally invasive placentation, and the future, where do we stand in terms of the science? Medicine is a science, medicine is also an art, and let's not forget that, right? So how does this condition occur? How does abnormal placentation occur? Now there's different theories, and I think one of the theories is this: low oxygen tension. And this was described by a guy who I know very well, Todd Rosen, and also by a guy called Norwitz and his groups, and Kelman also defined this. The theory is the following: whenever you scar the uterus, the scar leads to decreased oxygen tension. And the belief is that trophoblasts have a propensity of adhering to scarred parts of the uterus, to areas of low oxygen tension. So this is one theory, and there's many, many others. Kelman and his group believe that the trophoblasts have once again a propensity of attaching to exposed extracellular matrix. Once again, theory of hypoxemia. Scar tissue, decreased vascularity, hypoxemia, the trophoblasts will adhere to it. Now, if you look furthermore, if you look at Barish and Gainsky, and these are some infertility people, what they believed is the following. They believe that if you have low oxygen tension, so a lot of IVF specialists in the past, and I think some of them even today, before they transfer an embryo, guess what they do? They do a pipelle scraping, because they feel if they scar the endometrial lining, the implantation will occur a little better. All right, so this is something that people have also talked about by Barish and Gainsky. So once again, irrespectively, there is a lot of theories out there, but from you look from a research perspective, this is something which is interesting, and we have analyzed this in our lab back in New York. So if you look at the histology, unfortunately I can't point, the pointer doesn't work on this. If you look at the molecular pattern, the cytotrophoblast has a mechanism of moving into extravillous trophoblast. So the primitive cytotrophoblast looks like epithelial anchored cells. And as gestation advances from the first into the second and third trimester, they undergo this mesenchymal change in which they look more like an epithelioid in nature. So if you go across each trimester, in the first trimester, you see a transformation of these epithelial cells into more of the aggressive mesenchymal tissue. In the third trimester, it becomes less invasive. But interestingly, if you look at patients with AIP, their trophoblast is a little bit more aggressive comparatively to normal patients who do not have the disease process in the third trimester. And we have published this a couple of years ago in the Placental Journal. Now, irrespectively, this is exactly what happens. So if you look over here, this is normal myometrium. This is your placental villi, and this is your decidua. And what prevents the trophoblast from invading into the myometrium is this protective epithelioid layer, which is known as the Neutenbach layer, discovered by the Germans. So the normal uterus has this protective pink layer, the Neutenbach layer, which prevents the trophoblast from invading into the myometrium. The placental trophoblast, by the way, is no different than cancer. It really is. The only difference is if you look at it histologically, you don't have that alteration in the nuclear cytoplasmic ratio, but in terms of its behavior, it's very, very aggressive. So why doesn't it invade? Is because of the protective layer. Once you destroy this protective Neutenbach layer, the placental tissue will invade into the myometrium, leading to the entity of placental accreta. So once again, you could see on the far end, This is the trophoblast, and this is the myometrium. So if we draw a line, if you destroy that Neutenbach layer, then guess what happens? The placenta will invade right into the myometrium, leading to abnormally invasive placentation. So this is a diagram, and you could see this is healthy myometrium, decidua. You can see an area of a dent, most likely from the patient's prior cesarean section scar. So what happens is this area obviously has decreased oxygen tension. It's scarred, and you could see the dent, and you could see the fibrous tissue. So if you zoom this up, the primitive fertilized egg basically will implant in the area of low oxygen tension. It likes it. The trophoblast invades into the myometrium, leading to this entity known as the AIP, abnormally invasive placentation. All right, so this is exactly how it really occurs. And of course, depending upon how deeply it invades into the myometrium, you have the entity which we talk about, placenta accreta, which is superficial invasion. Increta, more than 50% of the myometrium is diseased, and percreta, when the placental trophoblast invades completely right through the entire thickness of the myometrium, and it basically invades into the adjacent organs. And the most common organ that you have in the pelvis is going to be your bladder. But this can also invade into the cervix. It can go into the parametria. If there's a posterior disease, it could go into the rectosigmoid. So this can become really, really parasitic. So if you look at this, this is exactly what happens. So if you look at a gross picture, you could see all three disease entities. You could see right here on the top that is percreta, and in the middle, this is increta, and here you could have superficial disease, and if you go lower, it's even normal. So you can have all three entities. Now, I want you to pay attention to this, because even though this is the disease process, the thing that occurs with abnormally invasive placentation that kills the patient is not really the pure invasion of the placenta into the uterine wall, but it is the following. As the placenta invades deeper and deeper into the myometrium, especially when it goes from accreta, which is superficial invasion, and moves into an increta, and then percreta, it triggers the process of neovascularization, no different than basically cancer biology and cancer physiology. So there's tremendous amount of mediators, especially like VEGF, you know, all of these endothelial growth factors occurs. There's a drastic increase in these vascular endothelial growth factors, which leads to recruitment of more vessels into the pelvis. So the disease is invasion plus recruitment of vessels, and it's the recruitment of vessels that leads to pathology. And we have described this very carefully and published it a few years ago, that once again, once you move especially to an increta and percreta, in patients with percreta, there is 100% neovascularization that occurs in the pelvis. And that is the problem, and that's why these patients die from hemorrhage, because of this tremendous amount of collaterals and vascularity that will occur. So if you look here surgically, when you open up the patient's abdomen, you see all of these vessels, and some of these could be venous, and some of them could be arterial. So if you see this tremendous amount of venous plexuses within the true pelvis, the last thing you want to do is put clamps, because it will rip and it will cause more disease, and the patient is going to bleed on you. So you have to be very careful. So the clinical significance of patients with AIP is obviously massive obstetrical hemorrhage. And of course, if they bleed, they could go into hypovolemic shock. You could lose blood. You could lose, of course, all of your products. They could go into DIC, surgical injury, because now you're panicking. She's bleeding. You want to put more clamps. You clamp the ureter, the bladder, so forth and so on. So there's more pelvic injury. And of course, there's injury to the viscera, the bowels. Of course, with massive blood loss, you end up having ARDS, pre-renal azothemia, renal shutdown, respiratory failure, and cardiac arrest. And if you look, globally speaking, the average blood loss in these surgeries could range between 3 liters to 5 liters, if not more. So these patients can have a significant amount of blood loss, so you should always be prepared when you're doing surgery on patients with AIP, all right? And of course, you can have the rare cases where you can have a spontaneous rupture of the uterus in the first or early second trimester. So moving on, let's talk about the epidemiology. So now we understand the pathophysiology of the disease process, and what I want you all to understand, it's invasion, recruitment of vessels. That is the disease process that you have to understand. So epidemiologically, the incidence of AIP has drastically increased all across the globe, right? So if you look at the 1800, in the 1930s, the incidence was about 1 in 30,000. By the 60s, 1 in about 19,000. By the 80s, 1 in 7,000. And today, it's really more than 1 in 1,500. Quite frankly, the number is maybe 1 out of 1,250 births will end up with AIP. So there is a drastic increase in the incidence of this disease throughout the whole globe, all right? And the issue is, why is there the increase? What do you think? More cesarean sections. But not only more C-sections, we're doing more uterine manipulative procedures, right? More DNCs, more hysteroscopies, more myomectomies, so forth and so on. We have become very, very aggressive surgically with some of these patients. So really, we are to be blamed as physicians in terms of why there is a rise in this condition. So whatever we can do as obstetricians and gynecologists to preserve the integrity of the uterus the way God created it is the best thing you could do for these patients, especially for those mothers who want to preserve fertility, right? So I think we should think twice before we say, oh, you need a myomectomy, oh, you need a DNC because you just had a missed AB, so forth and so on, all right? So once again, more cesarean sections. In fact, the study by Wu et al., 1 out of every 500 plus repeat C-sections resulted in Nicrita. And this number is actually higher. Now it's about 1 in 233 cases end up with a Nicrita. All right? So risk factors is quite a bit. Placenta previa on its own, irrespective of a C-section, puts you at risk of an AIP, even if she had no C-section, but the risk is low. Previous C-section, of course, the biggest culprit, myomectomies, Asherman syndrome because of multiple uterine manipulative procedures, myomas, maternal age over 35 or 36. So advanced maternal age is a risk factor. And by the way, and I'm sorry we have my infertility colleague here who I love a lot, IVF is a big risk factor. So you take IVF, and then you take the advanced maternal age, that's a significant risk factor for AIP. And we're seeing more and more of that, and our colleagues in Israel have even published that, and we see it, of course, even in the United States. So once again, be very careful. And of course, one more thing is this, multiparity, and you know that, an elevated maternal serum alpha-fetoprotein. So an elevated MSAFP in the absence of a ventral or neural tube defect on its own is a risk factor for AIP. So be careful when you see these screening tests. So once again, this is a no-brainer, but just to understand that if you have a placenta previa, the more cesarean sections you've had, the higher the likelihood of disease. So somebody with the 4 C-sections and has a placenta previa, she's got about a 50 to 60% chance of having the disease pathology, all right? Once again, the question is, why are we having more C-sections? I'll tell you why we have more C-sections in the United States is because of the legal issues. Nobody likes to talk about it in the United States, but that's the fact. Legal factors, people are scared of having a bad outcome and correlating fetal monitoring, recurrent decelerations with a baby who's encephalopathic, maybe that could have caused it. So one of the biggest causes of C-section is really the medical legal litigation, but there is many, many other more, all right? In fact, I was just in Tokyo about 3 months ago and I gave this talk. In Tokyo, the C-section rate is very, very low, but it's rising. And if you ask the Japanese, why is that? They tell you this, lack of adequate access or healthcare providers with the patient to the patient ratio. So if you have less obstetricians and more patients who are pregnant, then of course the obstetrician is going to be overworked. They have no time, and guess what? That triggers a higher incidence of C-section. But of course the risk is quite a bit. There's different cultural reasons. Some patients tell you, well, doctor, I want to deliver on Monday, June the 14th, because the moon and the sun are in the right alignment. I mean, you can get some crazy reasons, right? And people will come up with different things, but you have to pay attention to what's really triggering a high rate of C-sections, all right? And what has happened to VBACs or TOLACs, trial of labor after C-section? That has decreased in the United States also. I don't know how it is in Bahrain, but I'm sure it's also on the low side. So VBAC or TOLAC in the United States have dropped, so therefore your primary C-section is on the high side, so total C-section is high, so we're having a huge problem. So repeat C-section rate in the United States is close to 91%, if not more. So what we're trying to do in the United States is focus on primary C-sections. If you can decrease those primary C-sections, you're going to ultimately decrease this pathology, all right? So once again, in industrial countries, high C-section rate, and guess what? AIP is also on the rise. I was just in Egypt to give a talk, and guess what the C-section rate in Egypt is? This is not a right number, by the way. The C-section rate in Egypt is close to 58%. I was invited by the Turkish government not too long ago. Guess what the incidence of C-section rate in the private sector in Istanbul is? Over 60%, close to 70% in Turkey. Of course, the Dominican Republic, 70%. Brazil, China, the list goes on. So C-section rate has become an alternative form of birth, people, and we have to start focusing on this. And it's a huge problem because we are really paying the cost of it. I think in Bahrain, the C-section rate, right from what I saw, and correct me, you guys know better, it's about close to 30%. It's close to 30%, and I think the numbers are going to rise unless you people focus on it and do everything possible to decrease it. Just from the WHO, how many births do you guys do in Bahrain a year? I think it's about 21,000 births a year. 30,000, something like that. So what I did was I did a rough number, a rough calculation, but my numbers are a little wrong. From the WHO, 30% C-section rate, 21,000 births, but of course you said it's close to 30,000. So this is 21,000? This is correct? Thank you so much, everybody. All right. This was last night when I was jet-lagged. I couldn't sleep. You know, I woke up and I had to dig some statistics. But you know, you guys are paying right here close to $66 million. $66 million, and you have to look at your GDP over here also. It's not much, right? $66 million is spent just on C-sections, which is quite a bit. So from a financial, medical, economics perspective, you could really impact by decreasing unnecessary cesarean sections. So this is a pandemic problem. Globally, we're spending over $5 trillion, if not more than $6, across the globe with C-section. I'm sure Donald Trump knows about this because he likes money and he likes to decrease that. So let's not talk about politics. Now, how do you diagnose this condition? The diagnosis of AIP is ultrasound. No matter what machine you have, whether you want to use a Samsung or a GE or your Voluson, whatever you have, it's utilizing good ultrasound technology to make a good diagnosis. And I'm going to go over what are the things that you could look for to make you guys comfortable in terms of diagnosing it. Now, you can make this diagnosis as early as the first trimester. And I want you really to pay attention to me because this is very, very important for all of you as practitioners. You could make a presumptive diagnosis of AIP as early as the first trimester just by doing a simple transvaginal sonography. A simple transvaginal sonography. And this diagnosis can be accurate as much as even 95%. So this is what you do. In the first trimester, all you do is the following. You do a transvaginal ultrasound, the cervix being up here, this is the fundus of the uterus, and you divide the uterus in half. If your gestational sac is north, you're home free, right? If your gestational sac is below this line, then I think you should be concerned. And your concern should be, if the gestational sac is in the lower part of the uterus, is she going through an abortive process? Or, if she's not aborting, is that gestational sac in proximity to where her previous uterine scar was? So that's going to be the assignment. So, and you can easily make this, this diagnosis. So once again, so over here you could see the gestational sac is above the hemi-equatorial line, dotted line, so you're fine. But if you see it below that, closer to the cervix, then I think you could do some color Doppler and you could magnify and alter your gain of your ultrasound, and you could really make a good diagnosis. So once again, whenever you see this, if the gestational sac is low and the gestational sac is over her previous C-section scar, and you do some color Doppler flow studies, you can really sit down with this patient and have some adequate counseling and dialogue in terms of what she wants to do or how you're going to manage this patient. So clearly speaking, we can make the diagnosis of AIP as early as the first trimester with up to 90+% accuracy using Doppler flow studies and good real-time sonography. All right? So once again, if I look at this magnified, you could actually see there's a subchorionic collection here, the cervix is right up there, and you could see the niche where the scar is and the gestational sac, and you could see the primitive placenta right over there, right? So there's the scar, there's the placenta. So if you basically put some color, you already see some vascularity, you do digital subtraction, and guess what? So this patient, even as early as the 8th week of gestation, she is showing signs of perhaps abnormally invasive placentation. Keep in mind that if the placenta is really embedded and attached to that scar, as the gestational sac grows and the fetus moves, guess what's going to happen? Your placenta is not going to move, right? So that's going to be firmly adherent to the lower segment. So once again, you see gestational sac moving, but the placenta is embedded in its place, and it's not going to move. So the gestational sac moves away, but the placenta stay where the scar is. And you could follow these patients very carefully. So if you look at the progression of cesarean scar pregnancy into true abnormally invasive placentation, and I'll just show you images. You see, as the gestational age grows, you could see what happens in terms of the uterine size, but the placenta will remain in situ. And you could see the vascularity, once again, more and more vascularity as the gestational age advances. And we published this a couple of years ago by a colleague of mine, Ilan Timor at NYU, and we published this in terms of we followed the natural history of these abnormally invasive placentation and progression and vascularity until we had to operate on them, and there you are. You see a pelvis, lower segment ballooned out where the Balfour retractors are, and you could see significant amount of pathology. And the same thing over here, another image, just to show the progression, and it's the vascularity which is your biggest problem in this AIP, right? And of course, we published this a couple of years ago. Now, how do you manage cesarean scar pregnancy in the first trimester? I'm not going to go into this in detail because I don't want to take your time, because this is another subject, so I'm going to skip this. But to make a long story short, you have to counsel these patients aggressively. If you follow the patient and the patient ends up with a missed abortion, it's a blessing from God. So you just follow these patients by serial beta-HCG, make sure they don't bleed, and hopefully things go well. The challenge is, what if the patient continues to have a viable pregnancy? Then I think that's where it's more involved in terms of what do you do, and that brings a lot of ethical and religious discussions, so I'm not going to really discuss it in today's lecture. How do we diagnose it in the third trimester? Once again, ultrasound. Now I'm going to give you the tools of what you look for. So what are the signs of AIP on an ultrasound? So there are 3 grayscale markers that we look for: clear space, bladder line interruption, and lacunae. And then the other thing we look for is color Doppler markers, looking at all these abnormalities, the vessels. And I'm going to go into this in detail so you guys will be familiar with it in about 5 minutes or so. And of course, we'll look for a combination of grayscale and color Doppler studies. And the last thing we'll look for is this, is what I call the new generation of testing. We look at ACON, it means like Al-Khan, but nothing to do with that really. And we look at bladder flow studies. This is really what I call the new generation of testing, and this can be pretty much 90% to 99% accurate, all right? So the grayscale, this is what you look for. The first thing we look for in ultrasound is this. You need to see a good delineation between the placenta and the bladder by this hypoechoic region. So when you do good sonography, you should be able to delineate between the placenta, myometrium, and the bladder. This obviously has to be done with a patient who has a full bladder, at least 300 mLs of urine in it. If you see this, you could be comfortable enough to say that most likely she does not have significant pathology. Now, I'm going to jump. We can easily make a diagnosis of placenta increta and percreta, right? With today's modern day of ultrasound technology, you can make a 90% diagnosis of increta percreta by over 95 to 99 or even 100%. Our challenge until today is, guess what? Is diagnosing superficial disease, which is your creta. And this is why we're looking at biomarkers to diagnose superficially invasion. So superficial invasion is very, very difficult to diagnose. And remember, going back to the basics, the reason it's easy to diagnose deep invasion, because as you go from accreta to increta and percreta, you triggered the process of neovascularization. So ultrasound becomes easy. But the biggest problem is when you have superficial disease, it becomes very, very challenging. By the way, and that's no different than patients with early breast cancer. Early breast cancer, your mammogram or even now your MRI is not going to diagnose it. Same thing with ovarian cancer, right? We are very limited in diagnosing ovarian cancer, even by doing simple ultrasonography and some of the tumor markers. We're very limited. So once again, the same principle applies to patients with superficial pathology. That's very difficult to diagnose. But invasion, increta, percreta, pretty much 95 to 99 or 100%, you can make that diagnosis. So once again, look at the hypoechoic region. Going back, if you see this absence of this hypoechoic region, then I think you're in trouble. The other thing is, once again, you see the clear space right there. And if you lose that, then I think it's a problem. I'm not going to bore you into these guys. You know, Kromstock, Colli, D'Antonio, the Italian guys, they've described this, and they looked at clear space. What is the sensitivity, specificity, and the positive predictive value of picking up? And of course, there's all these numbers. And I think, you know, this is just all academic. And D'Antonio says that the clear space, the specificity is close to 95.8%. Once again, these are all screening tests. So the other thing which is very interesting is look at the bladder line. Not only losing that hypoechoic region, you also want to make sure you get a nice, clear, linear posterior bladder wall. When you see your bladder wall irregular, and then you do your color Dopplers and you see tremendous amount of vascularity, guess what? You made a diagnosis of placenta, increta or percreta, all right? So it's really, really not that complicated. Once again, you see here, tremendous amount of tortuous posterior bladder wall, and if you throw in your color Doppler, once again, this is complete placenta percreta, all right? So color Dopplers can be also very helpful. And I'm not going to bore you. Here's your numbers by Wong, Colli, D'Antonio, looking at the specificity, your positive and your negative predictive values. Lacunae. I think lacunae are very, very nonspecific because some placentas have lacunae within it, and it may mean nothing. But once again, people have looked into if you have more than 7 or 10 lacunae, then you can have more abnormally invasive placentation. I think that's more of a myth than a fact. But I'm just going to show you. So you can have physiologic lacunae, but once again, if you have lacunae, you have an irregular posterior bladder wall, you have tremendous amount of vascularity, then you're really looking at serious problems. All right, and here are some of the numbers. And I think at the end of the day, this is important, is these vessels. And you could do color Doppler and power Doppler also. So if you look at the summary from ultrasound perspective, and this is important, clear space, very important. Bladder line, you want it linear, not irregular. You don't want lacunae, non-specific. Tortuous vessels on the posterior bladder wall, problem. And if you see tremendous amount of vascularity on those tortuous vessels, then of course, you basically hit the jackpot. All right? So once again, when you have all of those markers, then the likelihood of pathology is definitely much higher. This is something that we did, and we worked with Oxford University a couple of years ago, and we published it, and I'm not going to bore you. We did a novel technology by using their bioengineering department, and I'm going to show you a summary of it. This is all you have to know. Whenever you have deep invasion, you have disruption of the spiral vessels, tremendous amount of neovascularization. So when you do color Doppler, this is a normal placenta. You can really see the spiral vessels. But in patients with AIP, this is what you see. It looks like a pancake. So this is what is called as ACON technology that we described. So the more the area of confluence, if the area of confluence is greater than 150 cc's cubic centimeter, then guess what? This is pretty much 99 to 100% predictive of percreta. 99%. And we published this a couple of years ago in the American Journal of OBGYN. How about MRI? How many people use MRI for AIP in this room? Great. European? Great. What country? Beautiful. I love Norway. Use anybody else? Now I'll tell you what's good and bad with the MRI. MRI is going to be a great tool to look for disease going into the rectus sigmoid because your penetrance of your ultrasound is not great. MRI is good for parametrial disease and invasion into the cervix. Otherwise, MRI is useless. And by the way, if MRI is utilized, it's also who reads your MRI. And that's the most important thing. Because if an MRI is read by people who do not know anything about this disease process, you're going to get a lot of opinions, a lot of noise, and it's all lies. And sometimes in medicine, you can be lied to too many times, right? So you have to be very careful not to be lied to. So the MRI is as good as somebody who really knows what they're doing, otherwise it's useless. So even for doing this business on AIP for over 18 to 20 years, we have actually 3 radiologists in our organization who do nothing but placental images and fetal pathology. So they really have become experts. And you become an expert just by doing this many, many times. So in fact, I go back to the room with the radiologist and I review the images also concurrently. So MRI is a great tool. And in Norway, you guys are doing some phenomenal things over there. But be careful in who reads it, all right? That's important. So once again, I'm not going to bore you. You could see the same things with the MRI. Thinning of the myometrium. Myometrial evaluation is much better by an MRI comparatively to an ultrasound. So that's something that I will tell you for a fact. So thinning of the myometrium, obliteration of the myometrium, and of course you could see more lakes and placental distortion. You can see this, but the color is the most important tool. You cannot see that with the MRI. Now, what's another thing you could do? So let's assume, let me give you this case scenario. You get somebody who is about 350 pounds. Do you guys see patients who are morbidly obese? Okay. So you take somebody who's 350 pounds, and she's had 4 C-sections. What do you think your ultrasound is going to do? You're going to get a lot of scatter, right? You're not going to see much. And if you get somebody who's also 350 pounds, sometimes, or 400 pounds, maybe they will not even fit through the MRI machine sometimes. Okay? So that becomes a challenge. Or if she's claustrophobic, and that makes it even more of a problem. So now how do we deal with these patients? How do we know the extent of pathology? And that becomes sometimes challenging. Well, you have to use clinical judgment. If you can't do a good ultrasound and you can't do an MRI, and the only thing you know is a history, and history is good, right? If she's had 4 C-sections and she has a complete placenta previa, then most likely you're looking at about a 60 to 70% chance that she has significant pathology, so you need to be prepared at the time of birth. But this is something you could do, is you could look at the bladder, and you could do simple office cystoscopy and make a diagnosis. And this is something that we published not too long ago. A normal bladder can have hyperemia, but you should not see abnormal vessels like this. You see the top one? That's neovascularization. People always believe that when you have AIP, you see placental tissue in the bladder. That's a myth. True AIP is vascularity in the bladder, not placental tissue, right? It's neovascularization. So when you do a cystoscopy and you see this, guess what she has? Placenta percreta. No discussions. If you see the posterior bladder dome, irregular bulging, and you see these vessels, and sometimes you will see arterial pulsatile vessels in the posterior bladder dome, that's pathologic. That means she has percreta. All right? And once again, if you see this in the bladder, she's got placenta percreta. And we published this actually a couple of years ago. Not a couple of years ago, just I think a year and a half ago in 2018 in one of the journals. So once again, that preoperative cystoscopy could diagnose the severity of AIP, and this is pretty much 100%. All right? Now, what we did is we took the same thing and we went backwards. We said, okay, so if we see this vascularity, then let's get a pulse Doppler on these tortuous vessels. So we filled the bladder with 300 mLs of urine. We looked at the vascularity. We threw in some pulse Doppler, and if we saw these waves, which looked no different than uterine artery notching, right? Then guess what? She most likely has placenta percreta. So once again, if you do pulsatility, and you see, this is not a good image, but you see this notching, then guess what? Most likely she has AIP. So 100% diagnosis, 100% of increta or percreta is following. Patient with a prior history, she's got a previa, bladder wall irregularity, neovascularization, loss of the hypoechoic region, she's got abnormal ACON, area of confluence, and if you see true pulsatile vessels that you can document on your color flow, then this is pretty much 100% diagnosis of abnormally invasive placentation. Now let's get to this surgical portion, which I think is going to be fun. Can we get the lights dim? We're going to show you some videos, but I hope you don't fall asleep. All right? Now, when do you think these patients should be delivered? Now, let's take some census. When do you think you should deliver a patient with abnormally invasive placentation? How many weeks? I don't know who's speaking. I mean, you guys look perfect, but I don't know, because the faces are covered, I cannot see it. Who was it? 34. Who said 34? 32, I like you. Thank 32, 35, 34, 32. What is it? 32 weeks. Okay. And by the way, you guys are all right. But I'll give you the real answer. If you have severe pathology, then guess what is the best time to deliver her? I'll go with you, with the 32 weeks of gestation. If you have disease which is there, but you think that she's got increta percreta but not invading into the parametria, and you think you can surgically handle her, then you could stick with a 34-weeker or a 35-weeker. But you never want to go beyond that. I'll tell you why. Because sometimes if you just go beyond 35 weeks of gestation, you're just asking for trouble, and the God is always going to reward you with trouble. right? So we want to stay out of trouble as opposed to getting into trouble. So be very careful in terms of when you do the deliveries. Now, when I give this talk, all the time, there's always, when I was in Egypt, they were about to throw shoe at me. Oh, what you talking about? You're delivering babies at 34 weeks of gestation. So my answer was the following. When would you deliver somebody if she has cervical cancer and she's pregnant? Invasive cervical cancer. When would you deliver them? Some people will tell you even as early as even 29 weeks of gestation or 30 weeks of gestation, and nobody will argue with you. But in a condition in which a mother could potentially lose her life, we are arguing about delivery of a 32 or a 33 or 34 weeker. Look, I think if the NICU cannot handle a 32 week and above, I think they should shut down. That's a fact, right? So I think in today's modern technology, we have neonatologists and they should be able to handle premature babies. Now, if you look statistically, the outcome of a 32, 33, 34, 35, and even 36-week premature baby is all the same. All of them up to 36 weeks have respiratory compromise. They're all going to have some degree of ARDS, right? Despite corticosteroids. Despite corticosteroids. If you want to decrease ARDS, then you have to wait to 37 to 38 weeks of gestation. Are you going to risk it with a mother who's pregnant with placenta previa and she's going to bleed on you in the middle of the night and you have no preparation? So preparation is the key thing. So the real answer is targeted delivery between 34 weeks of gestation. That's the ideal time. So once again, with severe disease, I would agree with you, much earlier in the game, all right? Now, it's important for us to understand pelvic anatomy. So going back to basics, right? Like today, this morning's talk on endometriosis, the professor talked about endometrial implants and pain, but everybody says the pain because of the cytokines released in the pelvis, that she has pain, and the patient always has pain here. Everybody forgets that there's nerves. There's blood vessels and nerves. What if that endometrial lesion is over a specific nerve that's causing that pain? Maybe you should tackle to basically excise that specific lesion over that nerve so it can alleviate the problem. Nobody thinks about pelvic nerves. We just focus on various other stuff. So going back to the basics of your pelvic anatomy, the abdominal aorta at the level of L3, L4 is going to bifurcate into your common iliacs, okay? And the common iliac at the level of the sacroiliac joint is going to bifurcate into your external iliac, which goes through your inguinal ring, becoming the femoral, and then the other one is going to be the internal iliac, which is synonymous to the hypogastric vessel. So the carotid of the true pelvis is the hypogastric vessel. So if you want to cut down the pulse pressure to the pelvis, then you need to ligate that entire hypogastric vessel. Now the hypogastric vessel is also going to divide into a posterior division and an anterior division. Most of the vascularity, meaning your vaginals, your hemorrhoidals, your middle rectals, your uterines especially, are all coming out from the anterior division of your internal iliac, which is right here. The posterior division, which goes all the way to your buttocks, gives rise to three divisions: your superior gluteal, your iliolumbar, and your lateral sacral. People say, well, if you tie the whole trunk of the hypogastric, people can get gluteal claudication. That's more of a myth. In patients who are pregnant, you never see that. So if you have to tie the hypogastric, you're better off tying the entire hypogastric vessel, all right? So if you tie the hypogastric vessel, you cause a 50% reduction in total blood flow, 22% reduction in mean arterial pressure, and an 85% drop in the pulse pressure. So tying the hypogastrics temporizes your pulse pressure, allowing for some degree of hemostasis and control. All right? Now, do you guys want to, do me show you a little clip of how to tie the hypogastrics? Okay, if we can make it darker here. So once again, I'm going to show you a little video. Oh, let's go back. Yeah. You there? Yeah, click on that. There you go. So once again, this is a Gibson's incision, which is nothing but a lateralized phalansteal incision. So this is a Gibson's incision. You're cutting the campus and scarpers, and this is the external aponeurotic sheath. External aponeurotic sheath, and you dissect that all the way to the anterior superior iliac spine. And then the next thing you could do is you get the internal sheath of the rectus. Now you could cut both at the same time, but you're going to take it up as high as possible. So once you dissect the internal and external sheath, the first thing you want to identify is your superficial epigastric vessel. You grab your superficial epigastrics, use two little hemostats, you clamp it and you tie it and you transect it. Because the last thing to do is if you put your hand in that area and you rip the inferior epigastrics, the patient will bleed on you. So after you've tied your superficial epigastrics, and you could use whatever suture material you like, you could use a Vicryl, you could use a chromic, whatever makes you happy. The next thing you do is you put your hand in there and you find a ligament. And that ligament is going to be the round ligament. The round ligament provides very little support to the pelvis. But the round ligament is vascular. It has the Samson's vessels right through it. You want to clamp the round ligament. It's very tendinous. You transect it and you tie it, and you do not have to put that together again. And the reason for you tying and cutting the round ligament, because it gives you more space to dig around in the retroperitoneal area to find the uterine vessels. So once again, the bladder is going to be more medial. You want to dissect with your finger more laterally, and the first thing you want to identify is the ureters. The ureters, and they will look like peristalsis. So once again, you could see the ureter, there's the ureter, and it's moving. See, this is the external iliac, that's the ureter, and that's your internal iliac, the hypergastric vessel. That's the external. You don't tie that because you'll cut off the vascularity to her leg. And if sometimes you don't know which one it is, guess what you do? You just put your finger on it and you tell your resident or your fellow, hey, can you feel her femoral pulse? And if they say no, then you're tying the wrong one. So you don't tie. So once again, you could easily do this. So this is the internal iliac that you can lift and you can tie. I usually put a double knot, and you could use any suture material that you want. You can even use a plain suture, and the direction has to be from, from lateral to medial. That's the direction you want to go. Now, I usually, when I tie the main hypogastric, I tie it as high as possible to the bifurcation area. And do you know why that is? Because if you tie sometimes the hypogastric vessel too low, then you create a dead space. And that dead space can form a big chunk of stagnation of blood, which can form into a clot. And if that clot gets dislodged, guess where it's going to go? To the patient's leg. And the patient is going to get an acute vascular occlusion, which can be a catastrophe. All right? So once again, that's important. So that's the extraperitoneal. This is the intraperitoneal approach. I'm not going to do this. But I'm going to show you how to approach a patient with AIP. Let's skip this because we'll go to the video right away. So let's click on this. So this is before we do any surgery. The first thing you want to do, patient is prepared, corticosteroids administered, and you do regional anesthesia. We don't put them to sleep. You give them combined epidural spinal. And then what we do is we do a cystoscopy. If you see bulging of the posterior bladder wall and tremendous amount of vascularity during your cystoscopy, then guess what your diagnosis is? She has placenta percreta, right? So once again, this is the trigon, and you can see nice urinary jets. And the first thing which I do is I put stents in the left and right. Ladies and gentlemen, stents does not mean you're not going to cause injury to the ureters. You could still put stents in, you can cut the ureters. It just makes identification of the ureter a little easier surgically. So after you do the cystoscopy, so once again, the patient gets a combined epidural spinal. The spinal is going to work right away. The epidural will stay longer in, and you can use that for post-operative pain management with these patients, especially when you do a lot of bladder dissection. These patients are going to get tremendous amount of detrusor spasm. So it's going to be more merciful if these patients are comfortable after the surgery. So after the cystoscopy is done, then you proceed to the surgery. Now, how many people believe you should put iliac balloon catheters or hypogastric balloon catheters when you do percutaneous surgery? Do you guys do that or not? No? Well, I'll tell you, it can become very helpful, because if you want to tie the blood flow, cut the blood flow to the pelvis, you can temporize the thing by either surgically tying it off, or you could do it by balloon occlusion. Now, if you see the vascularity to the pelvis, this is in a pregnant lady, you see there's tremendous amount of collaterals. So what we do sometimes in select patients, before we even open up the patient, we can place the balloon catheters by, the vascular surgeon does this. We put balloon catheters into the common iliacs and we leave it there. Because if she bleeds on you, and you have no time then to dissect into the retroperitoneal space to tie the hypergastrics, or you could just clamp the aorta, what you could do is you could put the balloon catheters and see what happens. So these are indications for placement of balloon catheters. If there's a true central previa, if the pelvis you think is frozen, it's a difficult surgery. If you have pathology extending into the cervix, extending into the parametia, rectosigmoid, then I think that's an indication for placement of balloon catheters. It's important that you place the right size in order for you to really cut down the blood flow, and you generally do that after cutting off the uterovarians. And you have 20 minutes, by the way.
Dr. Abdullah, you have 3 minutes.
3 minutes?
Yeah.
4 minutes. Okay, I'm going to go real fast. Okay, video. This is the most important part. Then we'll stop. So once again, actually no, go back again. Let me see. Can you click on this one? Okay. So this is what you do. Regional anesthesia, cystoscopy, balloon catheters only if necessary. You need to have preparation in the operating room. Preparation is the key thing. So if you have to put A lines, central lines, have blood available in the operating room, that's the most important thing. We have the argon beam coagulator, your hysterectomy tray, your vascular tray, we have bleeding boxes, and usually we do this in large pediatric operating rooms in our facility. Now, after you're ready, you do a vertical incision. You never do a phalansteal incision in somebody with placenta accreta. That's really asking for trouble. You need exposure, right? So you do a big vertical incision, all right? And after you do your incision, you want to go slow. You want to coagulate every bleeders, because hemostasis is basically the aim, and hemostasis is the game in these patients. After you do the big incision, I generally do an ultrasound in the OR to really demarcate the placenta. The last thing you want to do in patients with AIP is to cut through the placenta. She will bleed on you, and you do not want to do this. So generally what we do is we deliver the uterus very slowly, and you could see already the vascularity and disease pathology, and then we do an ultrasound intraoperatively to ensure that we are not even in close proximity to the placenta, and we generally do a fundal incision on the uterus and get the baby out from the top, away from where the previa and the pathology is. So we do an incision, and then we deliver the baby from there. Now, after the baby is born, you have to be careful not to squeeze, and this is a funny thing I'll show you. We have a brilliant resident. She was from Oslo. Yes, and look what she does. She's very excited because she goes, oh my goodness, we've never delivered babies like this. And then she starts pressing right over the lower segment. Look at this, with her finger. But nothing happened. The patient survived. But once again, see, the whole technique is you avoid injury to the lower segment, okay? So you avoid that. And then, of course, you assess and you do what you have to do. I'm going to move on because I'm not going to show you some other videos. Bladder, you have to be careful with bladder dissection, all right? And so forth and so on. So controlled surgery is the key thing when you deal with these patients. And you could see this tremendous amount of vascularity in these patients. And sometimes you may not want to do the surgery. In bad disease, you may just take the baby out, let it be, and then do what you have to do another time. Either embolize them, and later on do pelvic clearance a couple of days later, okay? I have 1 minute left. Sometimes we cool the pelvis. Conservative treatment is in patients with extensive pathology. If you think that the disease is really bad, then leave her alone. Do staged surgical intervention, okay? And staged surgical intervention means that we just, embolize them a few days later and then go back for pelvic clearance. And this is embolization. And to conclude, our outcomes that we have seen has been good. We have the lowest surgical ICU admission, the lowest blood transfusion rate, but unfortunately our babies go more to the NICU in these patients, all right? And to conclude, once again, I currently live, in our program we have lots of people involved. It takes a village to orchestrate patients, to help patients with AIP, so we involve lots of individuals. We have a good research team. I live in New Jersey, in Hackensack Meridian Health, which is one of the largest health work systems in the state of New Jersey. And this is just one of the campuses that I work at. I thank you for your time.
Thank you, Dr. Abdallah, for this comprehensive and really interesting presentation. I think a lot of our audience will want to ask him any question.
Questions? Yes, Doctor. I was expecting a question from you because you always ask questions, which is good. I like that. Go ahead. Thank you.
OBGYN department, and I really enjoy it. But obviously, there's a lot of advance in this area. Now, my question, the placenta, when you deliver, because you avoided you did ultrasound and you avoided, incision, avoided the placenta. So what do you do? What do you do? You just leave the placenta and you give antibiotic, or?
No. You avoid incision into the placenta,
Yeah.
and then you basically do your definitive surgery. Your definitive surgery ultimately in patients with extensive disease is a hysterectomy.
Yeah.
So if you enter into the placenta, she's going to bleed on you.
Yeah.
That means you're going to be doing an erratic surgery to just acutely stop the bleed, and your surgical comorbidities are going to rise on you. That's number one.
Yeah.
So if you leave it in, if you can assess and do the hysterectomy, then that's what you do. In patients who have extensive pathology and you feel that you cannot do the surgery because there's too much vascularity, then as long as she's not bleeding abdominally or vaginally, because you have to assess both areas for these patients, we place them in a semi-Fowler position so we can access the perineum at all time. If they're not bleeding and there's bad disease, you leave it alone, you embolize the patients, and then maybe 7 to 10 days later, you take them back and you then do the hysterectomy. Now, in very rare cases, by the way, we have left the placenta also in situ. We didn't even touch it. The longest that you could wait is really generally after about 6 to 8 weeks, they will bleed on you. 6 to 8 weeks, they'll bleed on you. So surgery is obviously, at the end of the day, definitive. There was a case that we had who was referred to us from Columbia University in which she had disease going to the rectosigmoid parametria and she was inoperable. Inoperable. Sometimes when you do laparotomy for advanced ovarian cancer, you open up the patient's belly, you say, listen, there's a mental caking, I can't touch you, you'll die. And it's not going to alter the outcome. You leave them alone and you say you're inoperable. So what we did in this patient is we radiated her. She started bleeding a little bit and we gave her external beam irradiation to basically shrink things.
What about the place of methotrexate? And
Methotrexate,
in cases of,
right.
if you want to preserve their uterus.
Right. You know, methotrexate, and I did not go over it because of time, is only useful in placentas that are replicating. After you deliver the baby, guess what you do to the placental circulation? It cuts off. And furthermore, it only works on rapidly dividing cells. So methotrexate is not going to work on non-proliferative cells, right? It works on a certain stage of your cell cycle. You know, you have your G1, G0, G2 phase of the cell cycle. So in non-rapidly activated, non-dividing cells, it's not going to do much. But we only leave it for those patients who, if you deliver them, the baby, and you're leaving the placenta and the beta HCG does not decline. Because you'd be surprised in about 2 to 5% of patients with AIP, they behave no differently than patients with placental site trophoblastic neoplasia, where these patients are not only maybe a candidate for methotrexate, but perhaps a second agent.
Thank you very
I hope that I answered your question.
Thank you very much.
Yes, doctor.
Regarding the Cesarean section defect, which is we can find it accidentally around 30 even to 80% of the patient during the ultrasound, routine ultrasound. Do you think repair of this defect or the niche, it will reduce the chance of the accreta or precreta or increta?
The answer is no.
Okay. Even if she's, regarding, I'm talking about the patient if she's asymptomatic. But patient, if she is symptomatic, this is a different issue. But you think this will not reduce the chance of abnormal implantation?
Just repairing a defect in the uterus?
Yes.
The answer is not going to. Because remember, the more you intervene surgically, the more scar tissue you're going to form at the end of the day. So I think the best thing you could do is just to leave it alone and hope that the implantation will not occur over that scar. Now.
But it may occur.
What's that?
But it may occur, the implantation.
Of course it may, because remember, if you have scar tissue, you have hypoxemia, it can implant. Now, one thing, listen, I will share with my brothers and sisters, even though I work in the United States. What we're doing right now, and this is something that I got approval by the NIH, is hopefully it will work, is I'm injecting stem cells into the uterine scar. Perhaps that will help with regeneration without surgical excision and repair of a niche that you see within the uterus.
Same like PRP?
Basically.
Mm-hmm. And this is, it's okay, another one or no?
Yep, that's fine.
Do you routinely doing the MRI for any patient, even if you are diagnosed that you diagnose already the placenta accreta or increta, or you go only with ultrasound if you are sure from your diagnosis?
I think ultrasound is completely enough for you.
No, your guideline in your institution?
Well, in our institution, we do it for all of them, and the reason we're doing that is because we're doing continued research, okay? Because we're still looking at the validity of MRI and ultrasound. But from a personal perspective, if you are comfortable enough with the diagnosis just with a simple ultrasound, you do not need to do the MRI. Now, if you think that she has disease going more laterally or posteriorly, then your MRI is going to be valuable.
Thank you.
Yes.
Any question?
Yes? You can stand up and scream, it's okay.
I cannot hear.
I can't hear you. I think you need to use it.
Thank you. How do we explain primigravidas having placenta previa with no risk factors?
Well, remember the incidence of placenta previa is about 0.5%, right? Generally speaking, the lower segment of the uterus has decreased vascularity to it comparatively to the fundus of the uterus, which is more vascular. And this is why by default, you can have a complete placenta previa even in the absence of a prior C-section scar. So it's the theory is because the lower segment is less vascular, that's why you get it.
The last question,
Okay.
Anybody?
Any other questions? No?
Just, yeah.
Okay.
Please.
Thank you very
This
much.
is the last question. There is one question. Just last question. Yes, please.
I mean, tocolysis, prophylactically using of tocolysis, I don't recommend it, right? Because
as in progesterone or something?
No, no. I mean, remember, progesterone is not really a tocolytic agent. It alters the quiescent phase of the myometrium. If you need to tocolyze the patients, then you do it for whatever reason. But prophylactic tocolytics, by giving them, either Procardia or whatever agent you guys use, is of no value. Absolutely. Thanks. Okay. Thank you very much.
Thanks a lot, Dr. Abdallah, for that presentation. The second speaker is Dr. Katrina Lim. You have seen her yesterday and today about pregnancy and obesity.
Okay, thanks again for the invitation. Today my talk is about obesity in pregnancy. I have no conflict of interest. I'm going to go through the definition and classification of obesity, a little bit about the prevalence and determinants, and then the complications related to obesity in reproductive health, and shortly about the long-term consequences. This is how we define or calculate body mass index, BMI, and that's the easiest way to classify overweight or underweight and obesity. This is the table, this is the classification that the WHO recommends for the BMI classes. Normal weight is BMI between 18.5 and 4.9. And obesity is also classified to 3 different classes. Obesity has increased worldwide. It's tripled since 1975. And in 2016, according to WHO, 40% of women in the world were overweight, and even 15% had obesity, which means BMI more than 30. Overweight and obesity kills more people than underweight today, and obesity gives increased risk for severe illnesses like cardiovascular diseases, stroke, diabetes, osteoarthritis, and even some cancer types. Obesity is associated with different environmental factors, lots of behavioral and cultural factors, a little bit about genetics, but mainly it's the imbalance between calories consumed and expanded. We have more access to food today overall in the world, and we have decreased need for physical activity because of the technology that we are using, unfortunately. We published this paper last year in Journal of Public Health. This is based on the Norwegian Medical Birth Registry, where we register all women giving birth in Norway. 219,000 of these have registered also the BMI. And we have lots of women from different parts of the world. So we classified the woman's country of birth according to World Bank classification of countries. And then Norway is used as the reference country in all analyses. It showed that women with low education had doubled risk for obesity and overweight. Living on the countryside increased the risk for overweight and obesity with 80%. And as we all know, increasing age also increases the overweight and obesity. And we saw a difference in maternal country of birth. Women who were from sub-Saharan Africa had the highest risk for obesity, 15%, and women from Middle East or North Africa had the highest prevalence of overweight in general, 44%. And this is a poster I found just outside here. This is a study done here in Bahrain. Doctors al-Radi and al-Yufairi, and this figure shows that only 22.8% of women in the study in Bahrain had normal weight, and more than 50% of the women had obesity. So this is quite worrying picture. But congratulations for the authors for a nice study. I don't know who you are, but obesity and overweight also has an effect on women's fertility. Polycystic ovarian syndrome, we heard about it more earlier today, and it's the most common reason for ovulatory disorders. Women with PCOS have insulin-resistant hyperinsulinism, and luckily enough, only 5 to 10% weight reduction will restore the ovulation in most of these obese women. Then back to pregnancy, maternal complications related to obesity. This is a report from UK for 261 maternal deaths related to pregnancy. At that time in UK, in general, the obesity among pregnant women was 24%. And this report shows how maternal mortality doubled with increased BMI. Of the women who died, 50% had overweight and 30% had obesity. Of the women who died of thromboembolism, 78% were obese, and of the women who died of cardiac disease, 60% were either overweight or obese. And this figure shows how the cardiac disease was the most important reason for death in this report. So in general, you can say that obesity increase and maternal morbidity, it increases type 2 diabetes, chronic pre-pregnancy hypertension, thromboembolism, stroke, cardiac disease, and also mental health problems. And directly pregnancy complications, we can list gestational diabetes, preeclampsia, gestational hypertension, and preterm birth, and many others, but these are the main complications. Again, I'm going to show from the study in Norway with 219,000 pregnancies with registered BMI. This table shows how gestational diabetes increases from 1% to 12%. It's about 10-fold if the woman with normal BMI less than 25 and compared with women with more than 40 in BMI. And you can see that it successfully increases in every weight class, BMI class. And the same trend we can see in type 2 diabetes. It increases from 0.1 to 2, so it's a 13-fold increase. And as expected, there's no association to BMI when it comes to type 1 diabetes, because this is totally a different type of illness. The same pattern we can see in obesity and hypertensive complications. Women with normal weight have 2% preeclampsia, and women with BMI more than 40 have 8% have preeclampsia. This is a 4-fold increased prevalence. And pregnancy-induced hypertension, the same pattern with 6-fold increase. And in pre-pregnancy hypertension, chronic hypertension, also the same pattern, a 13-fold increase from normal weight to more than 40 in BMI. And this is a figure that shows how these mentioned illnesses are associated to the different BMI classes. So you can easily see that all the illnesses are more frequent in the highest BMI classes. Obesity and preterm birth, the risk of extremely preterm birth before week 28 is increased with 3.5-fold from a BMI less than 25 to BMI 40, and preterm birth before week 34 is also doubled. And if we look at preterm birth in general before week 37, it's it's 40% increased. Delivery complications. All of us who work in the labor suit know how much challenges we have with these big ladies. We see more obstructed labor, poor uterine contractility, more need for oxytocin augmentation, postpartum hemorrhage, difficulties with anesthesia if the woman needs anesthesia, more cesarean sections, and more complications postpartum like wound infections, and of course thromboembolism. This table shows how obstructed labor increases with 20% from among newly posed women, from normal weight women to women with more than 40 in BMI. And even in parous women, the risk of obstructed labor increases with 46%. Dystocia shown in this. Please take a picture so you can use it later. You can also get all this in handouts. This is a study that we saw the delivery method according to maternal body mass index. I'm going to present the C-section rates in this study. This is a smaller study from Oslo, our local university hospital, with 8,800 pregnancies with registered BMI. Only term deliveries with more than 37 weeks, and only singletons in this study. This is our C-section rate. You see it's extremely low because in Scandinavia we work hard to keep it normal, in this study among newly parous women the C-section rate was 16, and among parous women 4%. This is a result of hard work. And here you can see how, again, the increasing BMI increases the prevalence of C-section in both groups, even among parous women who have previously given birth normally. This group doesn't have any previous C-sections. Even in this group, it's threefold. Fetal complications. Large for gestational age babies are more frequent among women with obesity. Stillbirth risk is increased. Congenital anomalies, probably because in the ultrasound screening in early pregnancy, it's more difficult to detect them. Risk of prematurity we have already presented. And then we come to the moment of delivery. The shoulder dystocia, Erb's palsy, clavicular fracture, and asphyxia and hypoglycemia are the most important problems that we see here. Again, from the register study in Norway with 219,000 pregnancies with BMI, and this is this picture shows how the prevalence of large gestational age baby increases from among women with less than 25 in BMI to up to 40 in BMI. So this is a threefold increase also. These are not adjusted for diabetes. These are pure prevalences. Stillbirth increases with 2 to 3-fold for from every BMI class up. Erb's palsy is about 6-fold increased when we compare women with normal weight and women with more than 40 in BMI, but you can see that it's a linear increase in every BMI class. Clavicular fracture is doubled when the BMI is increasing. And this illustration shows the same numbers in columns: clavicular fracture, Erb's palsy, and stillbirth in different BMI classes. Long-term health consequences, as I already mentioned, raised BMI is a major risk factor for non-communicable diseases, cardiovascular diseases, especially mainly heart disease and stroke, and this is not only for old people. These risk for these diseases is strongly increased already in younger groups among our women who are in infertile age. And cardiovascular diseases is the leading cause of death in the world. Diabetes, of course, as I have shown, musculoskeletal disorders because of the whole high weight, your knees and pelvis is stressed. And clearly increased the risk for female cancer types like endometrial breast, ovarian, liver, gallbladder, and kidney and colon cancer. And then we have this poor baby who is born for the woman with overweight and obesity. This child has a clearly and strongly increased risk for obesity in childhood and also in later in life, and unfortunately also for cardiovascular diseases and mental problems. So, take-home message is very simple. Obesity in pregnancy is a major health challenge all over the world, both for the mother, the fetus, and the newborn, and the child, the offspring later in life. I think we can all agree that weight loss is difficult, but it's beneficial, and as doctors and healthcare professionals, we should help our patients to try it, but it's not easy. We should focus on regular physical activity and limiting the intake of energy-dense food. This is my lovely obesity research group in Oslo. As you can see, only one boy and lots of nice, wonderful women. Shukran.
Thanks a lot, Dr. Katrina, for your excellent presentation. And any question from the audience? Okay.
The question was about litigation in our country. Well, in Scandinavia, we are very lucky. We don't have big problems with the litigations, and we, as I said, we work hard to keep the C-section rate in a normal level. But we are also lucky. Our women are willing to give birth. They want to have a natural birth. There are very few women who wish C-section. Also, of course, we have some women with a fear of delivery, but mostly Scandinavian women want to have a normal delivery. So this is not a big problem for us. And as you saw, we have much less, for example, overweight and obesity. We have less hypertension, less diabetes. So our women giving birth also have much lower risk profile. So in a way, it's also easier for us to keep the delivery normal, because women with BMI more than 40 is a rarity. I can count it in few fingers how many of such patients I have seen in 30 years. So it's really something special. And we also deliver breech deliveries vaginally. So that's and twins. So we managed to keep the C-section rate in general on low level, and that's why, for example, what we just heard, the invasive placenta is also a rarity. We have like 3 or 4 in a year in our university hospital with 10,000 deliveries. So for us, it's like, oh wow, we have 1 pregnant woman going around with the invasive placenta, and we informed the urologist and gastrosurgeons and the radiologists that this is coming in some weeks. So we have a very, very normal population. And we use a lot of instrumental vaginal deliveries, forceps and especially ventouse, vacuum. A lot, very much.
Okay. Any more question? Yes, please. Ada, yes. Ada. Anybody? Okay.
Everything is clear?
I think that's all. Thanks a lot, Dr. Katrina, again. And we'll start again at 4:15. So you can take coffee or something and come back, please, at 4:14. Thank you.